learning objectives, cranial nerves, number and name, classification, nuclear origin, attachment to brain, intracranial course, exit from skull, distribution and function, three-order ascending sensory neuron pathway, upper motor neuron and lower motor neuron pathway, pre and post ganglion pathway of autonomic nervous system, clinical assessment of functioning of each cranial nerve. The learning objectives of cranial nerves, please note, because you will be asked in viva and also in short notes. This component is very important. Again, I repeat, cranial nerves, number and name, classification, nuclear origin, attachment to the brain and intracranial course, exit from skull, distribution and function. Three-order ascending sensory neural pathway, upper motor neuron and lower motor neuron pathway, pre and post ganglionic pathway of autonomic nervous system. Clinical assessment of the functioning of each cranial nerves. Now see, attachment of the cranial nerves is olfactory, oculomotor, olfactory, optic, oculomotor, your trochlea, trigeminal, abducens, vestibulocochlear, hypoglossal nerve, accessory nerve, facial nerve, glossopharyngeal nerves, and vagus nerve. Now, sensory cranial nerves, olfactory, optic, and vestibulocochlear. Motor cranial nerves, oculomotor, trochlea, abducent, accessory, hypoglossal. Mixed cranial nerves, trigeminal, facial, glossopharyngeal, vagus. Please note the classification: sensory cranial nerves, olfactory, optic, vestibulocochlear, motor cranial nerves, oculomotor, trochlea, abducent, accessory, hypoglossal. Mixed cranial nerves, trigeminal, facial and glossopharyngeal, vagus. Now, the first cranial nerve, the olfactory nerve, the olfactory organs, the olfactory nerve, olfactory tract, cupriform plate of ethmoid. You please, we have beautiful original ethmoid bone. Please ask Bhavinash and at least hold it in your hand for a minute to see what it looks like. Now, the olfactory epithelium, the distribution of the olfactory receptors on the left side of the nasal septum is shown by shading. And it is the connection with the brain. The thalamus is the hypothalamus, your prefrontal cortex, olfactory bulb, amygdaloid, hippocampus, and cranial nerve 1, olfactory nerve. Before testing nerve function, ensure patency of each nostril by occluding turn and asking patient to sniff. Once patency is established, ask patient to close eyes. Occlude one nostril and hold aromatic substance, coffee, beneath the nose. Ask patient to identify substance. Repeat with other nostril. Now eyes closed, patient occlude nostril and stimulus scent or perception of non-occluded nostril. You see, when you go to purchase a deodorant or a perfume, actually big stores who sells perfume, they have coffee seeds. They first ask you to smell the coffee seeds, and then they spray one perfume on your hand, and you ask, you do this. Again, you want to see, no, you give me that perfume. Again, they ask you to a container containing coffee seeds, and again, once you smell the coffee seeds, the coffee, the smell deletes the perfume aroma. Am I clear? Now, similarly, actually, eyes closed. You have to close the eyes because he'll see the bottle or anything, the substance of this thing. He'll recognize, and then he'll just say this is this. But you're testing now olfactory dysfunction, anosmia, inability to detect your odors, inability to anosmia, inability to detect odors, hyposmia, decreased ability to detect odors, dysosmia, distorted identification of smell, parosmia, altered perception of smell in the presence of an odor, usually unpleasant, phantosmia, perception of smell without an odor person, agnosia, inability to classify or contrast odors, although able to detect odors, ageusia, inability to taste, hypoageusia, decreased ability to taste, dysageusia, distorted ability to taste. You please know the terms and what does it mean. So, olfactory dysfunction in this title, if you have it in your book, it's well. If you don't have it, then you search your mobile, go to ChatGPT or Gemini, they'll give you the answer. Now, cranial nerve 2, optic nerve. See, optic nerve, cranial nerve 2. This is the eyeball. This is the optic nerve here. And optic nerve 2, eyeball, your retina, optic nerve, optic tract, optic chiasma. The other day I told you, and lateral geniculate nucleus of thalamus, lateral geniculate nucleus of thalamus, optic radiation, visual cortex, the optic pathway, and now optic nerve, visual acuity, Snell chart of distance vision, Jagan chart of the newspaper or fingers for near vision, visual fields, confrontation, fundi or optic disc, visualization of the termination of the optic nerve by looking through the pupil with an ophthalmoscope. The other day I discussed that you, when you go to clinics, you have a small ophthalmoscope in your clinical box and you can see it. Now, optic nerve color vision test is done with an Ishara plate. This is affected on color, blindness and optic injuries, loss of red color. Now, visual fields. You just know the names and then you what it says. Visual acuity. You now ophthalmoscopy, the standard, the panoptic ophthalmoscope. Veins, optic disc can be seen, macula and arteries. Now, pupillary light reflex. When the amount of light entering the eyes increases, the pupils constrict. Functions to help the eyes adapt extremely rapidly to changing light conditions. Direct light reflex, same pupil constricts. Indirect light reflex, pupil of the opposite eye constricts. Now, light stimulus, optic nerve, optic tract, pretectal nucleus, then Eden third vestral nucleus, ocular nerve, ciliary ganglion, interpupillae, short ciliary nerve. Now, Edinger vestral nucleus can be a short note or it can come in MCQ. Now, optic nerve, what is optic nerve atrophy? That nerve atrophy is due to some it might be some blockage in the blood vessels or some injury. Now, distribution of facial nerve, cranial 7, facial nerve, distribution of facial nerve. Now, get the medulla oblongata and you see the path. And the vestibular is the cochlear apparatus. This is the ear. And now, parasympathetic, this is the gustatory fibers, taste, the branchial motor fibers, nerve to stapedius, the ossicles, and pterygopalatine ganglion, and to the eye lacrimal apparatus. Now, nerve to stapedius, the submandibular ganglion, anterior two-thirds of the tongue, salivary glands of sublingual glands, submandibular gland, the motor fibers to muscles of the facial expression, and chorda tympani nerve joining the lingual nerve. Now, cranial nerve 7, facial nerve sensory and motor. Sensory taste to the anterior two-thirds of the tongue, motor facial expression and secretion of saliva. Wrinkle, forehead raises and lower eyebrows, smile and show teeth, puff cheeks, close eyes, observe for symmetry. When you test for that, the functions accordingly. Now, this is the Bell's palsy. Bell's palsy, clinical features, loss of forehead wrinkles, inability to close eyes, wide palpebral fissure, epiphora, loss of nasolabial fold, drooping of the angle of the mouth, dribbling of food while chewing and affected side. Now, this you see in clinics, in your chamber or in your clinics, any person, can be a child, it can be an adolescent girl and a man or a woman. They come suddenly, sometimes what happens, there's lots of, there is cold and then suddenly he or she comes with a drooping and your angle of the mouth stretched. You have to take care. You have to, Bell's palsy is a common occurrence. It occurs especially in winter. Then you have to take and give some exercise and also antibiotics, steroids, and they can be referred, recover. Another thing is that anyone with the Bell's palsy or even transient ischemic attack of the brain a stroke, mild stroke of the CVA. Now, shunt, the shunt. So you ask the patient to blow the shunt. Most of the Hindu families, they are having that. Even if a patient is your Muslim, then you ask her to buy a small shunt. That doesn't matter because the full muscles and muscular condition, yeah, in four times a day or 3 times a day. That will give an exercise to the thing and also some massages. Now see, this is the bitter taste here, sour, salty, sweet. Okay. Clinical features. Now vestibulocochlear nerve, cranial nerve VIII, vestibulocochlear. Now see the cochlear apparatus. Now this is the vestibule. Vestibular nerve, pons, from here the pons, it goes, enters. The cochlear containing spiral ganglion. Vestibulocochlear nerve is going from the pons, is this. And this is the vestibule and semicircular canals. The inferior aspect of the brain, the vestibulocochlear nerve in green, the posterior part, the vestibular branch in green, vestibulocochlear nerve. Now, Rinne's test, method of testing for cochlear components, Rinne's test, Weber's test, absolute bone conduction test, Schwab's test, audiometric test, and evoked response. Now, if any person comes with deafness, then this is sound. You just bang, it is like this. The instrument is. It is in this shape. You just make it, just sound. You put it here in the forehead, which is bony conduction. It goes into the mastoid process and to the ear you can hear. Now if you see the right, again you put it in the mastoid, this portion, you put it in the forehead, it can be put in the mastoid process to conduction deafness. If there is any conduction deafness, then audiometry tests are there. This is Rinne's test that if you are a general GP, if you are GP practicing general physician, then you have it in your table. A small ophthalmoscope, small otoscope, and this to see your sound, hear the things the patient will perceive. Now this is the test of vestibular function. Observe equilibrium as patient walks or stands. Observe abnormal eye movements. Ask for dizziness, falling, nausea and vomiting. Now this is the audiometry room. It's totally sealed and this is the machine. Now the audiologist, he will adjust some sound and that you have to just signal. You can hear. So this is the test, audiometry. Now glossopharyngeal component is a mixed nerve, function motor, stylopharyngeal muscle and assist swallowing. Function sensory, general sensation and taste from posterior half of the tongue and pharynx and carotid sinus and carotid body. Function secretomotor, parotid gland. Now glossopharyngeal nerve. See, with the pharynx, this is the tongue, this is the parotid gland, this is the carotid body. Glossopharynx. That means tongue, pharynx, glossopharyngeal nerve. Now, glossopharyngeal and vagus nerve, uvula and gag reflex. Uvula get the patient to open their mouth and inspect the palate with a torch and note any displacement of the uvula. Ask the patient to say ah. If the uvula is drawn to the one side, this indicates unilateral 10th nerve palsy. Unilateral 10th nerve palsy, the uvula is pulled towards the normal side. Now, if my right side is affected, as gag reflex or uvula or plus gag reflex, you put your tongue depressor and then you will see the uvula. The uvula now if the shift of the uvula is to this side, that means this side is affected. And if it shifts to this side, then this side is affected. The uvula will come like this. The uvula goes this way. So these are your clinical methods that you can see the ninth nerve sensory component, 10th nerve motor component. Now test gently with the gag reflex, and the ninth nerve supplies taste from the posterior to third of the tongue. This is not routinely tested. Now gustatory pathways, the gustatory cortex or insula. This is the insula, thalamus, and see the posterior part of the tongue, the anterior part of the tongue, moving facial nerves, 7, glossopharyngeal nerve, the gustatory pathways. Then the vagus nerve, 10th nerve, a mixed sensory and motor nerve, wanders into the thorax and abdomen, parasympathetic innervation of organs. Now the vagus nerve. See the pathway, the heart, the lung, the liver, the stomach, spleen, kidney, your intestine, small intestine, colon. This is in one picture you can relate, and the vagus nerve. Now, preservation of airway is most important goal. Patient exhibit lack of abduction during inspiration and good phonation. Inspiration and good phonation. Now, expiration. There is a laryngology, bilateral adductor paralysis. Bilateral adductor paralysis. Eleventh cranial nerve, accessory nerve. Now you can see the accessory nerve to soft palate and pharyngeal muscles. This. The trapezius muscle goes here. Spinal root C1 to C6, external branch of the accessory nerve. You can see Sternocleidomastoid, yeah, test. Testing the 11th nerve. Weakness of sternocleidomastoid, trapezius on the same side, ipsilateral peripheral accessory nerve lesion. Ipsilateral peripheral accessory nerve lesion. Weakness of the sternocleidomastoid and contralateral trapezius, upper motor neural lesion, and lesion on the side of the sternocleidomastoid. Inspect both the sternocleidomastoid, trapezius muscles, wasting and fasciculation. Upward shrug of shoulders, loss of trapezius. Test for trapezius. You just shrug and put your hand here and like this. Then you can see the difference. Now, weakness of the sternocleidomastoid and contralateral trapezius upper motor neural lesion on the side of the sternocleidomastoid. Weakness of the sternocleidomastoid and trapezius on the same side, ipsilateral peripheral accessory nerve lesion. Now, 12th cranial nerves, hypoglossal nerve. Hypoglossal nerve runs inferior to the tongue, innervates the tongue muscle. See, hypoglossal, below the tongue, hypoglossal, below the tongue. Now, you can see the medulla oblongata, intrinsic muscles of the tongue, hypoglossal canal, hypoglossal nerve, extrinsic muscles of the tongue. Now, hypoglossal nerve palsy, it is normal tongue muscles pushing towards the lesion, weak tongue muscle. This is normal side. The tongue shifts. That means this is the weak. Right and left hypoglossal nerve palsy. See. This is right side. This is the left side. You can see the tongue. That's why tongue examination. Tongue is an important organ that gives you many clues regarding the surface. If it is coated, thick coated, high pyrexia, then it goes in favor of your typhoid. So when you go to clinics, you don't think that this is to be lost. This knowledge you have to gain, acquire and retain. You have to gain, acquire and retain the knowledge of the cranial nerves, and you have to practice quick examination in your clinics. Okay, this much for today. I didn't repeat the CSF because two occasions I said about it. Today I give you the cranial nerves. Now please go home, because under surface of the brain, if you given in practicals, then they will ask, what are this? Or what is this olfactory nerve? What is this now? Okay, thank you.